to this second session of the 8th scientific seminar that in this occasion has been focused on lessons learned from COVID-19 and also the remaining questions we still have. I would like to thank the speakers for accepting our invitation to collaborate on this event, and also all the attenders for joining, of course. Finally, I will also extend my gratitude to my colleagues in the Training Commission and also the IISPV Secretarians for the valuable work organizing the sessions and taking care of all details that are a lot. Also, I would like to introduce my co-chair, Dr. Papandreou, that is here, who will help me to guide the session today. Hope you all enjoy the sessions. And just to remind you that after each session, the virtual floor will be open for questions. We expect a lot, let's see. And also if someone has problems with the microphone or whatever, so you could just type the questions you have on the chat box, either during or after the session. And then we will read these questions when each session is ends. So now just let me to introduce the first invited speaker, Professor Jason Halford, who is already in the call and could see him. I had the opportunity to collaborate with him years ago and to collaborate with his great value. And then it's a pleasure for sure for me to introduce him to you all today. I met Professor Jason when he was the head of the Psychological Science at the University of Liverpool and the deputy head of the Institute of Psychology, Health and Society. And he is the current head of the School of Psychology at the University of Leeds, so it's also in the UK, of course. Professor Halford has a long experience and contrasted experience, international experience on appetite, eating behavior and weight management interventions, has led and contributed to several national and international projects. In fact, we met each other due to a European project on this field. He has also extensively worked with different stakeholders. This is also something that we have to highlight, including societies, including non-governmental organizations, policymakers, industry and advocacy groups to promote healthy foods and to develop more effective approach to weight management. He was the chair of the UK Association for the Study of Obesity, the treasurer of the European Association for the Study of Obesity, and now is the president-elect of this European Association. He will talk today about whether living with obesity increases the risk of COVID-19. So Jason, thanks for coming, and the floor is yours.
Thank you very much, and I'm really pleased to be joining you today. Obviously, under different circumstances, we'd be meeting together, but perhaps under different circumstances, we would not be talking about COVID. Now, I'm going to talk a little bit about COVID and obesity and risk factors, picking up on some of the things that you've already discussed in this excellent meeting, some of the topics covered yesterday. And then I'm going to talk a little bit about the impact of the COVID pandemic on people living with obesity, whether they've been infected with COVID or not. So to start, I'm going to talk a little bit about obesity and COVID-19, prevalence in obesity admissions, clinical outcomes, pathways, and social determinants. Well, from the very beginning of the pandemic, we noticed the prevalence of obesity in patients with severe COVID was far greater than was the prevalence of obesity in the general population. And here's some very early French data published in the Lancet, and we can see the prevalence of the infection in the general population is low compared with patients with severe obesity. You can see Lyon in the darker grey. Patients in critical care, much higher level, and obviously we can see particularly in patients in critical care in Lille, the prevalence of obesity is much higher. So from the very beginning in hospitals, we could see that there was a disproportionate number of people living with obesity in those units compared to the general population. And obviously, having obesity prolonged the hospital stay of these patients as well and impacted on shedding. So we can see patients with obesity were required to be in hospital for longer compared with those without obesity when infected. They required more time to clear SARS-CoV-2 compared with those without, and they also had higher inflammatory markers. And I believe you talked a lot about inflammation yesterday, and that's quite critical because obesity is an inflammatory disease and COVID produces inflammation. So there is a link there. Now, here's some very basic data, and we can see again that BMI status on the left-hand side is linked to increased hospitalization, is linked to increased intensive care admission, and those are both UK and English data. And on the right-hand side, from a meta-analysis, we can see it also increases the requirement for mechanical ventilation, which, as we know, is quite an invasive procedure. So in summation, what we knew last summer already was that COVID, there was a significant association between obesity and COVID severity and poor outcomes, but also what was going on in the background when the people, whether they were exposed to COVID or not, that COVID-19 cause a diversion of attention from the prevention and care of all other non-communicable diseases. It had an impact on cancer treatment, diabetes treatment, cardiovascular treatment, and also obesity as well. And that was literally because resources were pulled and pushed to the front line and were more generally disrupted. And I'll talk a little bit about that. But in surmise, people living with obesity were at or are at increased risk from severe illness due to the virus, increased risk of being COVID positive, increased risk of hospitalization, 113%, increased risk of intensive care unit admissions, increased needs of critical care, and unfortunately increased mortality. And they were likely to suffer and be less likely to be responsive to treatments. Now, those outcomes in second and third waves should have improved, although I've yet to see the data on that. And also, we got much better in handling obesity in COVID, in obesity in critical care. But still, the picture for people living with obesity is quite bleak, and the communication of the risks has had a significant impact on people living with obesity. Now, this is a quite interesting slide, and it's a plot of national overweight prevalence. So that's above a BMI of 25 rather than above a BMI of 30, which defines obesity. And so national overweight prevalence, so overweight and obesity combined, and COVID deaths in each country. And what we can see is prevalence of overweight plotted against mortality produces there is a positive correlation. But look, when we get to 50%, so go on the y-axis to 50%, we can see that correlation becomes much stronger. So for countries with overweight and obesity above 50%, the correlation is much stronger. And just for out of the same WOF report, which was quoting these figures, what is the situation in Spain? Well, the adult population with overweight and obesity is 61.6%. So obviously there is a much stronger link between overweight and obesity and COVID death in Spain and many European countries where levels of overweight and obesity are above that 50% marker. Now, there are various pathways linking obesity to worse clinical outcomes in patients with COVID. And here's an early model from EASO, from the Scientific Advisory Board. And we know that obesity increases abdominal pressure on the diaphragm, displacement, impaired ventilation, cardiorenal stress, blood pressure, thrombogenic potential, and that has an impact on cardiorespiratory fitness and susceptibility to inflammation, including cardiovascular complications. There is also metabolic impairments, low-grade inflammation again, and immune hyperreactivity, increased viral shedding, increased viral load, metabolic complications, dysfunction of the immune response, and viral exposure. And this all contributes to worse clinical outcomes in patients living with obesity. That's the biology of it, but I think it's important to remember, even in a COVID situation, hospital admissions directly attributable to obesity, or where it is a factor, are linked to deprivation. And this is UK data from Chris Whitty, our Chief Medical Officer. He usually talks a lot about COVID. In fact, he reports on the press conferences we used to have daily with the Prime Minister on COVID. And this is a slide from his presentation. And what we know is the hospital admissions directly attributable to obesity are greatest in the most deprived areas. So we've got a scale of least deprived, 10, to most deprived. So these are deciles. And we can see that the hospital admissions directly attributable to obesity are much higher in the most deprived. And we can see on the right-hand side, the graph in light blue, we've seen the same picture where obesity is a factor. So it's not the directly attributable, but it's certainly a contributing factor. And again, we see that difference between deprivation, where in the most deprived areas, the admissions are more than double for obesity as a factor, and they're more than triple for directly attributable obesity. So that's the graph on the left-hand side, the dark blue one as well. And this brings us more to a more broad public health perspective. So social determinants of health, obesity, chronic disease, and severe negative outcomes from COVID are interrelated. Okay, so social determinants of health, be it racial, ethnic, access to healthy foods, access to healthcare, location, physical environment, socioeconomic status, educational opportunities and achievement, and social and communal context all contribute to obesity, all contribute to chronic disease, and all contribute to severe outcomes from COVID directly and also through their interactions as well. So we have, in terms of public health, what we would call quite a storm, I would say. Now, I'm going to talk a little bit about eating behaviours and COVID. And now we're not talking about being affected by COVID. We're talking about the impact of the COVID pandemic on the population as a whole. And what we saw in broad terms was initially lockdowns led to sustained shifts in dietary patterns and levels of physical activity and worsening mental health. And I'll come on to talk about the mental health aspect in a little bit, a personal interest of mine as a psychologist. Now, wave one saw strained food systems and supply chains due to concerns around food shortages. And it became a self-fulfilling prophecy. The concern about food shortages actually produced food shortages, as many shoppers, certainly in the UK, stripped supermarket shelves. We saw increased reliance on processed foods. You couldn't get pasta or tin foods for love nor money. They disappeared completely. Reduced consumption of fresh fruit and vegetables, oddly. Changes in eating behaviour due to lockdown, especially for children. They were quite marked. Food insecurity amongst vulnerable due to reduced access to foods, reduced access to food assistance programmes and school meals. And certainly we saw actually a big impact. The UK already has great food inequalities and lots of food insecurity. And during the pandemic, we saw that particularly badly, where the lack of access to foods at schools, socially provided food, disappeared. There's also, we found increasing evidence for increased marketing of unhealthy, high fat, high sugar and high salt foods during the pandemic. And there is some evidence, although it's not in this presentation, that this was specifically targeted to children who obviously were at home. Now, that would be on television, possibly, a lot on social media, and particularly the use of Instagram as well, particularly things targeting at kids, social media influencers. So to investigate things further, the EASO, the European Association for the Study of Obesity, with our partners in the European Coalition of People Living with Obesity, commissioned the European study. And I'll talk a little bit about that. But the effects on children's diet and health, well, here's an early Italian study looking at changes in some basic indicators of health in terms of nutrition, health behaviours and activity, and the impact on weight as well. And what they saw was an increase in daily meals, an increase in the intake of crisps, or potato chips, red meat, sugary drinks, increase in screen time and reduced support. Now, interestingly, also in Italy, they saw an increase in fruit intake and an increase in sleeping time. I don't think we would see an increase in fruit intake as well. And this was predictive in changes in terms of body weight gain as well. So we could see that. We can see that in the child population, and there's other data out there beginning to come out. Now, this had an impact in terms of policy in the UK. It seems not to have an impact on policy elsewhere to a degree that we'd like to see. Now, the UK was already developing an obesity plan, which would focus on the entire population, but would have children at the heart of it. Many of you will know that our Prime Minister, Boris Johnson, actually was hospitalized with COVID, and he took it personally related to his own body weight. And so he has, or the government has, to this date, pushed on an obesity strategy. So most countries have not included obesity in their national COVID response plans yet, but the UK, at least in public health terms, in certain areas that I've been campaigning for, has done that. So the UK approach to promoting healthier life was a ban on junk food advertising on TV before 9 p.m. and online, something I've been campaigning for 15 years. So that was great. Prohibiting sweets at checkouts. So to get rid of that kind of pester power from kids at the checkouts with their parents. That's come and gone. Supermarkets have done that on a voluntary basis and they've crept back. So this is to prevent that backsliding by the supermarkets. Banning 2-for-1 offers on junk foods, calorie labelling in restaurants and on alcohol, and mandatory front of pack traffic light labelling. So that's the UK traffic light system, which is it has the same mechanisms underpinning it as the Nutri-Score, the system derived out of France. Now, there has been some backsliding on this. Certainly industry has pushed back on the ban on junk food advertising, although the government seems to be quite firm on that one. And there's also been a pushback on calorie labelling from restaurants and on alcohol. Now, the alcohol industry seems to have won on that, but the government seems to be still quite firm on the restaurant one. But what the UK has not looked at is the cost of healthy foods versus unhealthy foods. And when we come to food poverty, we know that's an issue. And, you know, things like sugar tax, but also subsidies for healthier foods as well. Social inequalities and food policy. The government is policy blind on this. It refuses to admit there is an issue there until it's called out by influential people such as Marcus Rashford, the Man United and England football player, who has led a campaign on this and shamed the government into providing food for kids during the school holidays. But also what we need is better access to proven treatments for obesity. That's going to have a significant impact in terms of the hospitalization and priority for people living with obesity in COVID prevention and management. In the UK, we eventually got there. And I think most people now in their vaccination programs are looking at people living with obesity as a vulnerable group, whether directly or indirectly, because they have lots of non-communicable disease, which pushes them forward on the vaccination programs as they're rolled out. Now, I want to talk a little bit more about the mental health and psychological impact of COVID for people living with obesity. And it's worth looking at the population as a whole. And there are lots of studies out there now which has been published. Of course, first thing scientists did during the lockdown was actually thought, well, we can actually study what's happened, and lots of online questionnaires were done. And here's two ones which were early ones, which were also good studies, but also ones I have a link in. So Robinson et al. From my old university, my old group in Liverpool, looked at UK adults. These are adults of all weight status, and looked at the impact of the first wave. And it had a negative impact on eating and physical activity behaviours, 56% increase in snacking frequency. They increased the barriers to weight management, problems with motivation and inhibitory control around food compared to lockdown, and particularly declines in mental health predicted the overeating. So there is a link between health behaviours and mental health. Now, this is a study on the right-hand side, which Monica was one of the leaders in, and it's looking at a Spanish and a Greek population. It's interesting, during the first wave, Spain had one of the most severe lockdowns, and Greeks seem to be doing surprisingly well. But there were commonalities, but there were also differences in the samples as well. But there were high levels of emotional eating, external eating, unhealthier food choices, snacking in both the countries. What was snacked on were differed, probably because the cuisines are different, similar Mediterranean, but differ as well, but also differences in the severity of lockdown and access to food. There are high frequency of depressive symptoms and anxiety symptoms. I'll talk about those in context of the European study. And the severe pandemic and stricter lockdown in Spain, there was an association between lower restraint and external eating and increased anxiety symptoms as well. So again, we see a relation between health behaviours and mental health. Now, there was a direct impact on people living with obesity, and we saw that in UK services, and we saw that across Europe. For those living with obesity who had the opportunity for bariatric surgery, well, virtually all bariatric surgery was cancelled, unsurprisingly, and other forms of treatment, multidisciplinary meeting activity and clinics, they were reduced as well. So the picture is quite stark in the UK, but it was even more stark in Europe when we looked at our specialised comms, our state-of-the-art centres across Europe, over 130 of them, delivering multidisciplinary treatment to people living with obesity. Staff were diverted to the front line, and it had a similar impact on surgical procedures, patients and visits. So people living with obesity lost treatment options, not just surgical procedures, but lost their usual support and their ability to visit their primary care physician, their healthcare provider as well. Obviously, things slowly turned online and new ways of finding things were developed, but certainly the initial impact was quite severe. And here's a study from the US, and it's a retrospective medical chart review identifying patients with obesity from a medical clinic and bariatric service practice. And since stay-at-home orders were initiated, 70% reported difficulty in achieving weight loss goals, increase in stockpiling of food for 50%, increase in stress eating for over 60%, increased anxiety in over 70%, and increased depression in over 80% as well. And so what we see is similar things to the national population, but actually what we can see is it is at a greater level. It's the impact is greater in people living with obesity. And a brief survey from the European Coalition of People Living with Obesity showed concern about COVID was high. Only 19% were managing to eat normally, and 38% were struggling, and 43% were comfort eating, binge eating. 60% had lower levels of motivation, and 60% were struggling daily, that is, with their mental health. So what we did was commission the European study. So that was jointly between EASO and ECPO, based on this early data which had come in, both collected through ECPO and the earlier studies that I have shown you coming from the UK, Greece and Spain, and other reports coming in. And the European study was commissioned. It was 3,000 respondents living with overweight and obesity from 10 countries: Denmark, Italy, France, Portugal, Spain, Greece, Sweden, Israel, and unfortunately England, which seems to have a UK flag rather than the English flag on there. So I apologise to any Scots or Welsh people there, but that was the flag which was available to us, unfortunately. So it was pretty good sample, 44% male, 55% female. The average age was 41, the average BMI was 35, so that's quite high. So the aims were to understand the psychological impact of the pandemic on people living with obesity and the impact of COVID-19 on the family and home environments of people living with obesity, and also to look at the impact of food and marketing exposure, media messaging around health and eating behaviours as well. So it had that kind of secondary thing as well. I'll come back to that at the very end of the presentation. Now, there's an online survey of people living with obesity in Denmark, England, France, Israel, Italy, Germany, Greece, Spain, Sweden, and Portugal. There was a quantitative element, well-being, emotional eating, mental health, social isolation, plus brief qualitative things where people could put in their messages. It started on September the 8th, and it went on for 4 months. Now, we thought we kind of missed the boat, so a lot of it was retrospective, but what was actually happening were people, or some countries, were entering their second wave as well. So why did we do this? Well, we wanted to obviously articulate the needs of people living with obesity and provide and advocate for better support for them. But we also wanted to identify protective strategies for people living with obesity. So things that they'd come up with or solutions that they'd found, which is why the qualitative part was quite important. But generally, we wanted to provide an evidence-based support to national and local health systems in developing useful tools for the treatment and long-term management of obesity. And I think our next piece of work is to work with the 10 countries around the data and actually put in prospective elements of this to continue to monitor the situation of people living with obesity as we come out of those pandemics. And EASO will be keen to work with national partners in terms of seeking external support to continue with these studies, as well as sharing the existing data and do country by country analysis. But just looking on a countrywide basis, and I'm not going to talk about this at great length, the samples were very similar, but I'm going to talk about some country differences. And I've supplied the slides to the conference organisers. I'm happy for them to be shared as a PDF after this meeting as well. And, you know, please, if you have any questions, do come and talk to us. So, interestingly, we looked at diagnosed psychiatric condition and medical vulnerability, and we saw a great variation in diagnosed psychiatric condition, with the UK, Sweden and Portugal having very high levels compared to very low levels in Israel, France and Italy. Now, it could be that there are great mental health problems in these countries, or it could be the diagnosis of these are better. Looking at least one vulnerability, one other health vulnerability, we saw that was quite high across all countries, a little higher in England than other countries, fairly high in Spain, fairly low in Greece. That might relate to the diagnosed psychiatric condition, because we do know the link between poor mental health and poor physical health. Now, if we look at the diagnosis and shielding over the previous 2 weeks, the diagnosis, which we can look at the left-hand side, was fairly low in Israel, Greece and Sweden. Greece seemed to be fairly protective. Israel was fairly good at its response to the COVID. We see it's not so good in France, Portugal and England. And if we look at self-reported shielding, we see oddly shielding is low in France, although symptoms and diagnosis were high. But we saw it's very high in Spain and Italy, and we know for historic reasons why we saw that. Now, if we look at food insecurity, we've got lots of different measures of food insecurity, but this is a big one. Oddly, in a population living with overweight and obesity, 10% of our sample said they had not eaten for a whole day due to cost or access issues. And again, there was great variability here. And oddly, we could see it's worse in Northern Europe. Oddly, in countries like Denmark and Sweden, which we think of as having good welfare systems. In England, this is not surprising, because we know we have issues around food insecurity. And oddly, food insecurity is linked with obesity anyway. So we do know that there is that link. What used to be called the double burden, but it's now called the triple burden. And we can see England sticks out there. And again, that might relate back to poorer physical and mental health. These are all descriptive statistics I'm reporting to you, because we've only started doing the analysis, the statistical analysis and the qualitative analysis. But here's some quotes. And this is unfortunately from the UK sample. We're getting the other quotes from the other countries translated. The reason we're doing this is actually people in England don't actually say all that much. We found from the Mediterranean countries we got a lot more useful data, but we just need to translate it to do the traditional qualitative analysis. But we also have a machine learning, artificial intelligence analysis we're going to do as well. But here's the food insecurity codes. To eat healthy, you have to have the money to do so. Less variety with online shopping. And this one, again, there was a big outbreak out of home baking in the UK, making more cakes now, which has made eating worse. So there's a kind of rash of home baking going on, certainly in the UK. Now, this is the overall change in financial situation during COVID versus pre-COVID, and we can see 5% were better off financially, 48% were about the same, but 47% were worse off. And we saw that vary across countries. It's not so bad in Germany and Denmark, Sweden and France. In England, not so bad. England, Spain, similar. But we can see it's particularly bad in Greece and Portugal. But what we know about people living with obesity is they tend to be in low social economic groups. Their work would tend to be more likely to be affected by COVID. They might be on more casual contracts as well. So that's why we think there might be a disproportional impact potentially on them. But we don't have a normal weight comparison. So that's speculative on our part. So finances were difficult because I was furloughed. Money was tight because my hours were cut. I needed more financial support for the family. And the last one may go back to the food insecurity issue and not eating for a day, where children are prioritised in terms of giving resources such as food over the adults in the family units. Emotional well-being during COVID, well, we can see it was worse for 55% of the sample, improved for 8%. So some people had a positive story. It'd be interesting to look at their sample, their stories, and work out how they coped and whether there are lessons to be learned there. But we can see it's over 50% in most countries from France, Israel, Spain, England, Greece onwards. It's a little lower in Denmark, Italy, and Germany, but those are still very high levels. And so this is emotional well-being in terms of psychological distress, which is the graph on the left, emotional eating, which is the graph on the upper right, and loneliness. And those are all very high levels. We can see some greater psychological distress in the UK. Remember, they had higher psychologically diagnosed conditions going into this, but loneliness and emotional eating seem to be pretty high across the board. And this is just some sort of heat maps for you, so you can see the European spread better. So we can see anxiety. We can see it's particularly bad in the UK, Italy and Portugal, but not so bad in Germany and Denmark. If we look at depression in the middle, again, the UK comes out worse, but things don't look so brilliant in Portugal and Spain. And we look at the two scores combined, which gives you total distress, and the UK comes out worse, followed by Portugal and Italy, and it's quite bad in Spain and Sweden as well. If we look at well-being, loneliness and emotional eating, on the well-being score, it's worse in the UK, particularly quite bad in Portugal and Greece and Sweden. In loneliness, it's particularly bad in the UK, but it's quite bad in Portugal as well. But if we look at emotional eating, we can see a big picture in Portugal and in Spain, although it's pretty bad everywhere with the exception of Denmark and Germany. So here are some well-being quotes. Loneliness was the worst. I had to stay in due to lockdown, which made my depression worse. I didn't keep a routine. I exercised less. My stress level is high, and we know the link between stress, coping, and emotional eating. Nothing felt good at all. And the final one, went on social media too much and read negative comments that upset me. And we see a lot about, and quite a big part of the survey was devoted to social media. And I'm now going to share with you, and this is the first time I've been able to share some statistical analysis from the European study. We've done some preliminary work on the impact of TV and social media representation of obesity on distress, anxiety, and well-being. And first, I'll talk to the television part of it. So television, compared to before COVID, in terms of distress, experiencing more positive representative of people with larger bodies on television during peak exposure of the outbreak was associated with higher levels of distress. So these are positive images, but higher distress. And again, experiencing positive representation of people with larger bodies on television was associated with high levels of anxiety, but also high levels of well-being. So it seems perhaps viewing health messages and news reports on television is raising awareness of COVID and the impact of weight on terms of COVID health outcomes, which might have a negative psychological impact, but also is having a positive impact on people in terms of well-being. Certainly, the negative representations didn't have an impact on distress, anxiety, or well-being, and perhaps there weren't all that many negative representations on traditional broadcast media. It's worth knowing that TV viewing was the highest in Spain of all the sample, and that's over 5 hours a day. Now, I don't know how that relates to pre-COVID levels, but it might be due to the severity of the lockdown in Spain. Now, let's look at social media when compared with COVID. Now, social media is the Wild West, really. It's unregulated and there's a lot of fat shaming, memes and things going out there. And certainly people reported experiencing more negative representations of people with larger bodies on social media during the peak of exposure. And that was associated with higher levels of total distress. It was also associated with higher levels of depression, anxiety, and lower levels of well-being. So social media had a really significant negative impact. Any positive representation didn't seem to have any impact on distress, depression, or anxiety, or well-being. And again, with the exception of Facebook, people in Spain don't seem to use Facebook so much. Social media use in Spain was the highest out of all the sample, and that included YouTube, Instagram, Twitter, and TikTok, and all other forms with the exception of Facebook. And I think there are probably reasons for that in terms of lockdown. I don't think the Spanish per se watch more television and use more social media. I think this is a function of the lockdown and the first wave. So this is just a brief summary of the European study. During wave 1 of COVID pandemic, 55% of respondents felt worse off in terms of their emotional well-being overall. Around a third of the respondents had a diagnosed psychiatric condition with considerable variation between countries. And that may be related to the support, the social situation, but also the ability to diagnose and treat. So there might be some reporting bias there. 47% were financially worse off during COVID compared with pre-COVID, and a little bit more on this food insecurity. So 17% of the respondents skipped a meal during lockdown, 15% had gone hungry, and 10% had not eaten for an entire day due to costs or access. So that was the figure that I quoted. While almost 30% reported snacking much more often. We'd not done a particularly strong nutritional analysis in the survey because that work had already been done so excellently by some of the studies I'd shown. I'm sure we're going to see lots of systematic reviews and meta-analyses of this coming out, so we'll get a better pan-European picture, which we can link our survey to. So on behalf of ECPO and EASO, I'd like to thank the teams here, the University of Leeds, University of Liverpool, Cambridge University, ECPO and EASO, and this is the team involved. And in summary, I'd like to say living with obesity increases the risk of COVID hospitalization, critical care needs, and mortality. And there are multiple pathways by which obesity and excess atopic fat increases the impact and effect of the COVID-19 infection. That's biology, which is not my strong suit, so I don't speak to that too much, but you've already had some excellent presentations on that, much more up to date than mine. However, I think it's important to recognize that social determinants of health, obesity and chronic disease such as race, ethnicity, socioeconomic status, educational opportunities, food security and insecurity, and food and physical environments, and severe negative outcomes of COVID-19 are all interrelated. So they have direct effects, but they have an interrelated dynamic interaction as well. The pandemic has a negative impact on diet and health behaviours for children and adults, including people with living with obesity. And across the population, it's associated with changes in eating behaviour, depression and anxiety. But this is further complicated for people living with obesity who've lost access to support and their usual treatment. So all their usual coping mechanisms have gone. So they're severely challenged, and many people report gaining quite a lot of weight. And mental health issues are distinctive in particular for people living with obesity, particularly due to the need to self-isolate, disruption of usual weight control strategies, and reduce access to treatment and food availability, stress, and also self-stigmatization and stigmatization in the media, which just contributes to that. So in summary, EASO has lots of resources that are available globally, and I do encourage you to go and have a look at those. And you can follow EASO and what it's been doing at the following sites as well. So I thank you very much for attention. I don't know whether I kept to time or I've talked for too long now. So,
thank you. Thank you, Jason, for this interesting overview about what's happened during the pandemic, and also what will happen maybe in the near future. So now we have time for some questions. So I will open the floor for questions if there is someone in the call. You know that it's always difficult. So, well, I will start because I think everyone agrees that pandemic has have had a high impact on society in general, of course, but especially in obese people. So in those subjects who had obesity during the first wave, second wave, whatever. But my question is regarding the future. It's regarding the prognostic on obesity pandemia, because obesity was also a pandemia defined, if I'm not wrong, in 2016, but seems that has been forgotten because the new COVID pandemia. So what we can expect on obesity rates in the next year? So taking into account these changes in eating behaviors and also, of course, changes in mental health, what is the impact of COVID-19 on the incidence of obesity, and especially in children? Do you have data, or
I think we're still collecting those data, and because things like the school measurement programs have been disrupted. So literally your ability to measure children you can't do, because schools have procedures in place where classes cannot mix. The teachers are within the bubbles. So one of the issues we've got is monitoring. So that's going to be a big issue, and it'll be interesting to see what programs like COSI does, which is what we across most European countries in collaboration with WHO, and what things like because the UK isn't in COSI, but it has a national schools measurement program, what they do, because literally, no pun intended, we don't know the size of the problem. We do know about issues around food insecurity, but we've not got any direct measures of child health. But there are going to be medium and there are going to be long-term impacts of COVID. Now, those will be related to mental health. Those will be related to increased inequalities, and you'll see those in children, and those will be related to food security and the quality of diet, and that will have an impact on the child's growth trajectory. So certainly that's going to have a big impact, and we will need to monitor that. In the adult population, I think because we've had a lack of access to treatment and disruption to the food supply and continued disruption to the certain parts of the food supply, there is going to be an impact again in adults, and I think food will become more expensive, and certainly in the UK we have shot ourselves in the foot with Brexit. So in the UK we're going to have really big problems there, and we can already see it. The supermarkets are not stocking the range, and we had major disruption at Brexit due to not Brexit itself and customs, but actually France not wanting lorry drivers in without tests and things like that. So we had lots of things which just caused increased complications. Now, in the medium and long term, there is going to be an economic impact. So that economic impact will have an effect. We know the link between socioeconomic status and obesity, and employability, educational opportunities, and things like that. But also, we're going to have sluggish economies, poorer jobs, poorer job security, and we're not going to have a lot of money. So governments are going to have to try and dealing with large deficits. So perhaps healthcare resources will be cut. And there is pressure from industry which says that we need to get back on feet, and policies to deal with obesity, be it childhood or adulthood, are impediments to us getting the country economically stable. And you hear these conversations. So I think there's going to be a long battle. But what we do have is obesity recognised as a chronic relapsing disease now, and I think as Europeans we can work together, and we're keen at EASO EASO to work with all the countries with that data and see whether we can get follow-on studies based on our data and the data already collected in the country, because I think the data and continually monitoring the situation will mean that we'll find out where the problems are, and we can, with people living with obesity, advocate for solutions and policy action.
Yeah, totally agree. Is there any question?
I have one question.
Christopher, you
Yes.
have, of course you can ask.
Hi, dear Professor Jason, thanks for a nice presentation. I would like to ask about these campaigns about banning unhealthy foods, whether there is any data with serial measurements of sample in UK in which they saw improvements.
Well, the bans haven't technically come in. There was something which was regarded as gold standard legislation, which was a voluntary thing where companies said they wouldn't advertise to children, but the restrictions were so limited and they were literally voluntary, that it had no effect. We still saw that most of the food advertised during children's peak viewing time, not children's television, but when they actually watch television, not specific cartoons, which the legislation applied to, was completely unhealthy. And I think one of the things manufacturers always say is, oh, well, somebody did a ban, it didn't work. Something did this, it didn't work. You don't just do one thing, you've got to do all of them, you know. So I don't think that just removing unhealthy TV adverts will reduce obesity levels in the country. You've got to do all the policy options at the same time. And by and large, you know, if it's just advertising, if you remove them from broadcast media, they do advocating. If you stop them doing advocating, they use social media influences and YouTube, you know, and it escapes. So you've got to be much more on top of this sort of thing. So you've got to use all the tools in your arsenal. And it's interesting that the traffic light system and the use of the nutritional guidance to do that has had an impact on food formulation. But also the sugar tax, which is one thing they did bring in on drinks, had an impact. Now, did it cause more consumers to swap to the non-sugary versions? Perhaps a little, but what it did do has a major effect on producers in terms of reformulation. So it was less consumer behavior and more reformulation. Well, I'll take reformulation. I'm quite happy with that. You know, it's a win whichever way it acts. You need to be careful in Europe where you've got land borders and you can move between, because otherwise people just go, if they live near the border, might go over the border and buy the unhealthy, untaxed versions. You know, so if you did it in Spain, you could dip over to France or Portugal if they've not done the same policy measure.
Okay, thanks a lot. And for me, it was very interesting also in the survey that despite financially Germany, UK, it's much better than, for example, my country is Greece. They used to eat less in that country compared to Greece, for example, or Portugal. So I didn't understand very well how this is interpreted. So a country maybe has more inequalities.
Yeah.
Like so.
And I think there is a big lag, particularly in those two countries, from the financial crisis. You remember we went through a financial crisis 10 years ago, and I think there has been a big impact on those two countries, which is a legacy impact. Do you see what I mean? Which they carried forward into the pandemic. So although Greece wasn't particularly affected initially, it was starting from a place where it was quite vulnerable. And we see that from the global crisis over 10 years ago, the global financial crisis. Well, that shows how you get legacy effects. So imagine the legacy effects of COVID moving forward.
Yeah. So it was good to see these preliminary results of the European study. And also thinking about the past, if I'm not wrong, this higher severity of pandemics on obesity was already seen in SARS in 2003, and also in influenza, I think was 2009, and MERS in 2012. So it's like, you know, we are just repeating pandemia, and pandemia, of course, was not widely studied, probably because that pandemics don't spread so fast and to all the population, and of course, COVID has have had a higher impact. But just think about what you say on the social media, TV, press release, whatever. I'm just wondering whether we should try to control a bit more this type of media, although it is not good to control social media, but just to put them to work for society in order to not increase the burden of this pandemic. Because
I mean,
say
it's
that
a big,
more
it's a big worry for me, and social media is a big worry for me as well, because lots of people living with obesity, particularly in ethnic minorities, are being targeted by anti-vaxxers at the moment. And so those are the groups we saw, particularly because there are various reasons why people of differing ethnic groups, Afro-Caribbean, India, or from Pakistan heritage, suffered more, but living with obesity was a big factor. And those are groups which are being targeted very systematically by anti-vaxxers, particularly coming out of the US. And so the group is going to be doubly disadvantaged. So I worry not just about fat memes and general disinformation, but systematic disinformation as well, which is having a critical impact on vulnerable groups who are not being vaccinated, have more risk, and are living with obesity as well. So I think this is a big problem moving forward that we have to deal with at a European level, and really deal with those messages coming out from people who are stripped of their medical qualifications in the UK 20 odd years ago about objecting to the MMR vaccine and claiming it was linked with autism. These are the same people, anti-vaxxers. And so we do need to be very cautious in terms of people living with obesity, because they're going for them.
Yeah, thank you. Is there any other question from the floor? If not, maybe we can move to the next speaker. Thank you, Jason. Thank you very much for attending. We can clap our hands, but it's not normal in this type of virtual calls. And hopefully, the next occasion we can have a face-to-face meeting. Thanks a lot.
Excellent. I look forward to it. Thank you very much, and have a good week and weekend to everybody there. Thank you.
You too. Thank you so much. So next move to the second speaker today is Professor Alex Arenas, who probably most of you already knows, mainly because he's one of the most recognized and valuable voices in the field of COVID-19. Professor Arenas is part of our academic staff. So he's professor at the Department of Computer Science and Mathematics in our university, and is the director of the chair in Science and Humanism. He was accredited as a CRE Academia researcher twice, in 2011 and 2017. So congrats by duplicate, and along with other international awards he has received along his career. With more than 200 publications in high impact factor journals, including Nature, he has focused part of his career in the promotion and dissemination of the values of science to the society from the humanistic point of view. Alex has developed a mathematical model to predict the evolution of the COVID pandemic. So it seems that he has this glass ball that everyone knows, just to ask about the future. And this is what he's going to talk about today, about the chronicle of an onset pandemic, a mathematical model. Also, thanks, Alex, for accepting our invitation to the seminar, and the microphone is yours.
Thank you very much for the organization and for inviting me to present a little bit what has been our work on this pandemic using the models. I will share my screen now. Okay, now you can see?
Yes, perfect.
Okay, perfect. Then, as I entitled here, what we did was a mathematical model for the spatiotemporal epidemic spreading of the COVID-19. And this map that you see here in my first slide is simply the communication network by air flights, okay? And the first thing we learn from this small cartoon of our world is that we are totally connected. And this is essentially the main factor in the propagation of epidemics. Okay, let me start by quoting something that I like very much. That is the first paper that I consider in mathematical epidemiology, which was written by Vendrell, one of the mathematicians and physicist brothers. And he made this paper at a new analysis of the mortality caused by smallpox and of the advantage of inoculation to prevent it. And apart from the approach, which mathematically it's something grounded that was to be taken into account in these ages and nowadays, it's nice to see that he says, I simply wish that in a matter of which so closely concerns the well-being of the human race, no decision shall be made without all the knowledge which a little analysis and calculation can provide. Okay, and this is for me one of the main problems of the epidemics we have. I mean, the epidemics was from the very beginning highly concentrated on the medical, let's say, field. And I think it was an error not to take into account that epidemiology has evolved in our century to an interdisciplinary field where mathematics and physics are essential. Okay, then it's sometimes I say, I mean, it was complicated for me because the problem that we have was a problem like, allow me the metaphor, a problem of traffic congestion, right? And we were asking to people that were mechanics of car repairing, you know, and this has been very trouble during all the pandemics, but at the end, I think we have make our advance in the sense of considering those models are essential for the epidemic prediction. Okay. I would say that my talk started 150 years later after Vendrell, when a statistical physics started to shape the history of epidemic modeling. And the famous formula of the law of mass action by McKendrick and Kermack is the pillar of what I will explain here today. Essentially, it's like a chemical reaction, right, where you have individuals that are susceptible and individuals that are infected. And if a susceptible individual meets an infected individual with a certain probability beta, the susceptible individual get infected, and we have two individuals infected. Okay, and in particular for those diseases that you can recover from, the infected individual with a certain probability or rate mu, it becomes susceptible again. Okay. Let's go step by step to see how we can model something like epidemics. Okay. First of all, let's concentrate on the types of diseases. We have epidemiology in non-infectious diseases, for example, those developed during the lifespan of an individual, like arthritis. And this epidemiology, which was very well based in Spain, for example, is the study of risk factors associated with the chance of developing a disease. However, we were not so prepared in infectious disease that can be passed between individuals like human, animals, or plants. And in their epidemiology, what tries to compute is the main risk factor in the presence of infectious cases in a local population. It's a communitary approach to the problem. We will put our attention on those infectious diseases. These infectious diseases can be produced by microparasites that are small single cell like viruses, bacteria, or protozoa, or macroparasites, which are bigger like helminths or flukes. And we will concentrate on this difference because the infections from microparasites generally develop rapidly from a small number of initial parasites, and the internal dynamics of the pathogen can be known. That's important. When modeling, you should get what are the main factors in the process that you want to describe. Okay, if the internal dynamics of the virus can be ignored in this approach, this is very important. For example, if we were dealing with macroparasites, this is not the case because macroparasites have a complex cycle within the host that needs to be modeled explicitly in order to get inside. Okay, good. Then we have two types of transmission. Direct transmission, where there is a direct physical contact between the subjects that are exposed to the disease. The greens are susceptible and the red are infected, for example. Or indirect transmission, in which the disease among subject is done by a third-party agent, right? That is the case of vector transmission, for example, mosquitoes that can expand diseases. Okay, we will fix our attention in direct transmission and we will focus on the particular problem we have. Okay, during several months, you have been reading about the basic reproduction number, the famous R, which it was one of the descriptors that was offered on TV to see how the evolution of the epidemic was going on. The reproduction number basically is a measure of the expected number of cases directly generated by one case in a population where all the individuals are susceptible to this infection. Okay, let me put this in an example. If the reproduction number, for example, is 3, that means that an infected individual will produce 3 infected individuals, and each one of them, they will produce 3 more. Okay, this is essentially the basics of an exponential growth. And here I have a table for different diseases like influenza, Ebola, or COVID, where the R basic reproduction number, the R0, were 1.4 for influenza, 2 for Ebola, and 3 for COVID. Okay, and these are days and the number of cases that we accumulate in time. For example, in a plot here, you see the prevalence, and the total number of cases that we will have in days for influenza and Ebola, and you see that Ebola grows very, very fast, but I cannot plot in the same scale what happens in the same days if we have COVID. And the idea is that these two are the previous ones, influenza and Ebola, and here is COVID. Okay, that's the problem. That's the main problem of the epidemics. This exponential growth will synchronize so many patients that will break down any health system. That's the point. Okay? This is the main problem, and now the idea is to anticipate those cases and see how these cases will evolve in time and geographically according to the information that we have from data on the field. Okay? In a mean field approach, which is something that physicists are used to, which is an explanation of the main elements that compose the formula that represents, in particular here, the basic reproduction number. We assume that the infection probability per contact is defined by beta, and we compute the expected number of individuals that are infected in a time period, tau. And it turns out that after some very simple calculation, you understand that the basic reproduction number is a product of 4 factors. These 4 factors are tau, the time window duration of the infection period, beta, the infection probability per contact, K, the average number of contacts per unit time, and rho S, which is the fraction of still susceptible individuals in the population. Okay? And why I put these formulas from the very beginning without explaining any calculation and etc. Because it's super relevant. Here we have already all the information about what will happen. And what will happen is that to control the epidemics, we have to reduce this value of error below 1. This is the only way in which instead of growing, we will see a decrease. Okay? And then we can only act on these 4 parameters, which is in a product. That means that we can reduce one or the other or all of them, but we have to reduce according to these parameters. There is nothing else. Okay? Then, how can we reduce tau, the time of the infection? Easily, by early detection and isolation of these cases. If I isolate a case from the rest of the population, the infection period, which is the number of days in which you are infecting people, will be reduced as sooner as you get isolated. Okay? This is why it was so important to test. Okay? We can reduce beta, which is the infection probability per contact, but this is difficult because it's something that depends essentially on the virus. And we can reduce this if we have a drug that allows us to confront this virus once on the organism, or by physical protection. This is what we know as the face mask, and distance, right? Social distance. Is this trial to get the infection lower, the probability of infection, by trying the virus not to propagate between two individuals. The third one is to reduce the number of social contacts, the average K. Why? Because essentially each one of us, we are trying to contact different people, and if we are infected, it's like a lottery, the number of people that I will contact with, and the probability that if I am infected, I will infect others. Then the reduction of this social activity or social distancing through confinement tries to reduce this average number of contacts per person, okay? And lastly, we can reduce also the pool of susceptible individuals. And this is only possible with vaccination or by confinement, big part of the population, or in the case of immunity by infection, what was called the herd immunity. The problem is that, as you know, the herd immunity in this disease with so high R0, it's practically impossible because the number of deaths cannot be acceptable. Okay. Then at the very beginning, if we reduce our tools in absence of drugs and absence of vaccination, what you see here is essentially what you have been seeing through all the pandemics. Tests for early detection, physical protection with face mask and distancing, trying to minimize social activity, and confinement when the data was almost to collapse the health system. Okay. Having said that, let's go back to the epidemic paradigm, and let's see what is the main difference when we try to model an epidemical process. We distinguish between the medical status, in which you have incubated the disease and then you are diseased, or the epidemic status or the infection status, where we distinguish in a sort of compartments, like, for example, susceptible, exposed, infection, and recover. And here I plot what is the curve of the evolution of the pathogen in our body and the immune response that we activate. And you see that these delays are important to see how the pathogen is trying to grow, the immune response trying to fight back this, and at the end, probably, depending on the disease, of course, you get recovered. But these compartments are essential to understand what we are trying to present in time for this evolution. And in the susceptible, we say that there is no pathogen present on the host, and we are susceptible to the infection. When we are in the exposed compartment, the level of pathogen is too low to be infection, and probably you will not have signs of infection. Then you have a compartment where you are infectious, the level of pathogens is high enough to transmit to others, and you probably will present symptomatology. And finally, one compartment, which is the recover, is one in which the immune system, or unfortunately you die, but you are no more in the susceptible pool of the system. Okay. This is usually represented by the capital letters of each one of these compartmental models, and they are several depending on the disease. For example, you can have SAR for chickenpox, measles, or rubella. You can have SAR, which is the previous one, but ignoring the exposed compartment to be mathematically simple to analyze. There are other compartmental models like susceptible infected, which are infections for life. This happened many times in plants. There is the paradigmatic SIS, in which you are susceptible, infected, and you get susceptible again to the disease. And this is for example, very well suited to model sexual transmitted diseases or influenza, for example. And there are others like SIRS, in which you have a temporary immunity here in this compartment. As a mode of parentheses, perhaps COVID could be one of these latest epidemiological model if reinfection will be possible. We hope not, We hope to be in an SIR, but there is a non-null probability that we are in front of an SIRS. Let's see. We have to wait for the effect of immunity by the vaccines. Okay, then let's concentrate in one of these models, and let me explain a little bit how we construct these mathematical models to understand the full idea. I will concentrate in the SIS, and this is a classical example, and you can find books and mathematical analysis of these kind of models by differential equations. But 10 years ago, we proposed a new approach that was called the microscopic Markov chain approach, where the main idea is that instead of having discrete states for every individual, I mean, the individual is in the infected compartment or is in the susceptible compartment, and then you have simply a flag for each one of the individuals. What we could propose is that the individual has a probability of being in a certain state. Okay, this is the main change. Then our equations are like picking the equations of a discrete system where the states were discrete, and to convert these states in a probability state. You are probably susceptible or infected. In this context, we can be far more precise than in the previous one. We can construct deterministic maps for the evolution of these probabilities, which are the equations that govern the model. We can account for a specific contact matrix between the individuals. In the previous approaches, it is very difficult to put the contact matrix, how people contact with others, okay? And this is an information that amazingly is reported in many countries for how the society essentially have this network of contacts, okay? And this was very important to be accurate after in the COVID prediction. The solution of the model is very easy because it can be simply iterated because it's a discrete map, and we can prove some theorems on top of them, and we can define essentially the macrostates, the order parameters, which is essentially the question: what will be the average number of infected individuals in a population in a certain time? Okay, let's construct the equations. Look, the idea is very simple. Imagine that you are in a state, we will start from the left, which is infected. Then with a certain probability mu, you will recover, and then you will be susceptible again. Remember that we are in a very simplistic compartmental model, which is SIS. Then with the probability mu, I will be S again, and with the contrary probability, 1 minus mu, I will remain infected. If I am susceptible, with a probability Qi, that I will explain in a moment, I will remain susceptible, and with the contrary probability, 1 minus Qi, I will get infected. Then the idea is very simple. You start in this tree and you say, okay, what is the probability that we will be infected at time t plus 1? I start from here, I say, okay, I can come from this branch, or I can come from this other branch. Then I express this in the first equation. The probability of being infected, I am an individual I, at time t plus 1 is simply the probability that I was infected at time t and I don't recover, plus the probability that I was susceptible at time t and I will be infected, okay, with this probability 1 minus q. And the same for the susceptible, which is the contrary. What is the probability qi? Well, the probability qi is the probability that I contact with another individual, let's say J. This is controlled by this matrix, Rji, okay? The probability that this individual J will be infected, and this multiplied by the probability of infection beta gives the probability that J infects me. 1 minus this quantity is the probability that J will not infect me. Then Qi is the product that any of my contacts will not infect me. The contrary will mean that one or many of my contacts can infect me, okay? Then everything is closed in this equation. We can reduce these two equations to a single one in which we talk only about infected individuals, like here. And then having this, we can prove that this dynamical system of n-map equations with n time-dependent variables can be solved we have initial conditions at time equal 0, number of infected that we have at our starting point, the contact matrix between the individuals represented by this matrix RJI, the probability of infection or the rate of infection beta, and the probability or rate of recovery mean. We can prove this is more mathematically, but the system is a contraction mapping. That means essentially that it will have a unique solution and can be solved. Okay, here there is a plot in which we represent the fraction of infected individual as a function of the infection probability beta for a network which is constructed as a scale-free network, which essentially says that the probability, the number of neighbors that I will have scales as k number of neighbors to the minus gamma, being gamma an exponent 2.7, which is a good representation of how social networks are constructed. And here I represent what is the result of our theory, which is the solid line, and the results of a big simulation, Monte Carlo simulation of this system in which we move the particles, okay, and we infect each other, which are the red points. The probabilities identified by the analytical proposal and by the simulations are very in close agreement, okay? And this is saying that in principle, this approach to this particular compartmental model works very well. We started to play with this with several pandemics, and here we have a map in which we have a very, very large simulation of an epidemic that started in Osaka, for the H1N1, and the number of countries that will be affected with the probability of having cases on this country. And here in the bottom there is the same map with our model, and the difference between these two maps is lower than 2%. In fact, it's very difficult to see a place in which you detect different colors between one and the other. Okay, good. The nice thing about the model is that it can be solved analytically. It's not only a machine in which you put numbers and generate new numbers. You can get inside because it can be solved analytically. Okay, for example, we can calculate the epidemic session, which is something very, very important in epidemiology. Which means what is the minimum value of the infectivity of this pathogen that will make that this epidemic grows up. Okay, and this can be analyzed in the steady state. It consists essentially in picking the equations and getting right off the time. And near the critical point, there is something interesting. The probability of having infected individual is almost 0 because we expect a transition from no infection to some infection. Then you can linearize the equations, blah, blah, blah. I will not insist on this topic, but at the end, you will end up with an eigenvalue problems that determine the critical value of the infectivity of the pathogen, which is mu divided by the maximum eigenvalue of a certain matrix R, which in here is simply the contact matrix between the individuals. Okay, up to now we know how the network of interactions is important in defining the characteristics and evolution of the infection. But this is not enough, because in this photo, this is something like a snapshot, okay? I have a photo of the contacts between people and that's it, but people move. And this is a problem, because then we have to scale these models to meta-populations, with our patches that are connected by communication lines, and then you have infected individuals, but they start to move, okay? And when they start to move, they pass the infection from one place to another. Then infections in meta-population models are driven by mobility. Then in 2019, we took this problem and say, okay, let's try to scale our model to represent these meta-populations. And this is what I will present now before going to the particularities of COVID, okay? The idea is that now, instead of having individuals which are nodes in a complex networks of contacts, what I will have are patches, populations, like, for example, Tarragona and the communication lines with the different cities, Barcelona, Girona, whatever, okay? Then each patch is labeled by an index, I in this case, and it represents a population, okay? We say meta-population because we have many of these populations connected each other, Okay, then we can express the density of individuals which are infected by row I in the same way we did from the previous example, okay? The density of infected individuals in the population I at time t plus 1 will be the fraction of individuals that were infected and don't recover, and the fraction of individuals that were susceptible, that is 1 minus the infected, multiplied by the probability of getting infected. Okay, this probability has to be very accurate in the sense that this is the probability that a healthy individual, which is associated to this population, is infected at time t. Okay, associated to this population is important because each individual will have, let's say, a home. Okay, and then I can commute to Barcelona, but I go back to Tarragona because I live here, and it happens to any of us. Okay, then this is the probability that an individual from Tarragona is infected at time t. Where it is infected is the problem that we will now resolve. Okay, then we compute this probability according to the mobility P. P is a parameter, which is the probability that I go to Barcelona, Girona, etc. Then the probability that I will be infected in time t will depend on the mobility in this way. If I don't move and I get infected with probability in capital P in my patch I, or I move with probability P to those places which I am in contact. This is the matrix Ij now. Now is a matrix of roads or communication transport, and the probability of the infection in this place that I am going to go. Okay? Then this is the probability that an individual being unknown I or J is infected at time t, and we can express this probability again as the number of people that were infected in this node, in this population, and multiplied, which at the end this product is a power, to the number of individuals that commute from one place to the other. And this commuting probability is simply the number of individuals that we have in a certain population weighted by all the typical commuting lines that we have according to data to a population J, or not moving, 1 minus P, and being in the same population. Okay, you put all together this and you get an equation which is particular in this, and again, we do large computer simulations and the analytics of this particular model for the SIS and for the SIR for different values of beta over mu, and the dots as before are the results of the simulation and the solid lines of the analytic calculation. And in principle, again, we have pretty good accuracy. Moreover, we also can compute the epidemic threshold in this case for the particular equations that I have expressed. Is the same analysis. I mean, we go to the stationary state, we linearize. After linearization, we pick the main elements of this linearization and we construct the final expression for the parameter pi. Let me go to this particular equation, which seems cumbersome, but is not. Look, what happens here is the following. In the particular matrix that will control everything in the epidemic model, we have several terms. The first term is telling us, well, if I am susceptible and there is an infected in my place, let's say Tarragona, then I don't move from Tarragona with probability 1 minus P. The other node, the infected one, doesn't move from Tarragona, probability 1 minus P. The square of this multiplied by the number of people, and I got infected here. But it could happen also, this second term, that I am susceptible in Tarragona, I go to Barcelona, there is an infected there, and I got infected, or the other way around. I mean, I was here, some infected from Barcelona comes, and I get infected. Okay? And finally, we have a third term, which is saying, essentially, that I can be susceptible in one place and infected there. We move both to, let's say, Zaragoza, and then I got infected there. Okay? Then, this is important because it's revealing what is the role of mobility, and this role of mobility is not linear, is at least quadratic. And this will have effects in the control of the epidemics that are radically important. Okay, we'll go to the maths, we can solve this, and at the end we will find, again, an eigenvalue problem where the critical value of the infection probability is mu, the recovery parameter, divided by the maximum eigenvalue of the matrix M that I exposed before. When we go to networks that are synthetic, like Erdős-Renyi graphs or scale-free networks, and we plot what is the value of critical beta divided by the value of critical beta if we don't move, what we are asking to the system is, okay, mobility will be worse in terms of the epidemics. That means that will diffuse better the virus. And, well, if these curves are going down, the answer is yes. Then, here, as a function of the probability, I compare the critical beta if I move with the critical beta at p equals 0. If this goes down, that means that the critical threshold is approaching 0 and is more dangerous, okay? And what is saying here is that Erdős-Renyi graph and scale-free networks, they do answer yes to this question. I mean, if you move, it is worse for the epidemics. But then we went to real data. And in 2018, we have a contract with the government in Colombia, which shared the data from very large populations like Santiago de Cali, and we got data for 2.2 million people in 22 districts in Santiago de Cali, with 10 to the 5 trajectories that are represented here as this network of connections. Then we put our model at work, and we compute what was the evolution for every one of the districts of the epidemics following our approach, MMCA, or following a very, very large Monte Carlo simulation. And the answer was that, wow, we can predict pretty well what is going on in time. But then when we did the question that I asked before about what is the role of mobility, will mobility increase the danger of these epidemics? I mean, it goes down in this plot, beta over beta C, and the answer is no. That's very surprising. There was values of mobility for what? Up to this point, there is an epidemic detriment. The threshold increases. That means that it's better to move because somehow we are helping the epidemic not to progress. And this is totally counterintuitive. Okay, it's like, how can it happen? Okay, it happens. It happens because the mathematical properties of those non-linear effects that I commented before get us an analysis of the largest eigenvalue of the matrix that control everything, which is quadratic. And that means that for the values of the probability that you can go on, which is 1 over n, that means that at least one individual is infected, okay? We cannot go lower than this probability. And p, we can have the minimum of this parabola, which represents the quadratic dependence, in 3 different aspects. We can have always increasing because the minimum is before 1 over n. We can be in the middle, which is what happens in the previous plot that I showed you, or the minimum can be farther than 1, and in terms of probability, this is not possible, and we will have an increase always. Then we discovered 3 different regimes according to the mobility that in real population they turn out to exist in very different ways. For example, in Santiago de Cali, as I showed before, there is this increase and decrease. And in Medellin and Bogota, for example, always moving is favorable to try to control the epidemics. And this was the previous to the model that I will present, which is our approach to COVID. Okay? Then a model that considers mobility as the main element in the propagation of disease. Well, we use these formalists to model the spatiotemporal evolution of COVID-19 in Spain. Let me say a short story about how we do this. Okay, in January 2020, we were in a conference in Japan with a group, with my research group and other research group with which we collaborate. And we started to see on TV the epidemics in Wuhan. And in Japan, there was like some kind of tense calm, you know, because the data that came from China were already worrying the population there. When I came back, it was 21st of January. I went to my pharmacy asking for a face mask and hydrocolloid gel. Okay, and well, the people here was like, okay, are you traveling to China or something? I say, no, I mean, it's for here. I mean, it will come in less than a week. We have a communication by air transportation, which is daily and very intense with any country in the world, in particular China. What do you expect? It will arrive. Well, people thought that I was crazy. Perhaps it was a little bit. But we started to work with the group in trying to use our previous model and tailor this for COVID. And this is what we did in February 2020. Okay? We defined a compartmental model, getting the few information we grasped from the Chinese in the scientific literature already. Okay? And one of the points that we were worried about is the existence of asymptomatic transmission. And this was neglected by the vast majority of the medical professionals. And this was amazing for me because the data already showed that the propagation of this disease was not possible if there was no existence of these asymptomatic individuals that were transmitting but not detected. Okay? And this was particularly nice from the ship that was stuck in the coast of Japan, where we have already data of a closed group and what was going there. Okay, then we proposed an epidemiological model that was this one here, in which we have susceptible individuals, exposed individuals, asymptomatic individuals, infected individuals, and then all this part here, which is the recover part, was especially important for the COVID, because what we did is to decompose the epidemiological model in the epidemiological dynamics, SAI, and the clinical dynamics. Why? Because remember what I said at the very beginning. If you look at the growing of the exponential of the basic reproduction number in the number of cases, you know that the main problem will be in the health system. The health system will collapse if you don't do something. And this is the clinical dynamics. When the infected individual is hospitalized, the probability to go to the intensive care units or not. And the intensive care unit in particular was the main point, because the collapse of the health system was controlled by the capacity of the intensive care units that you will have, which in our country is limited as in any other country. And there is no country in the world that can cope with this reproduction number. Okay, moreover, we understood that the incidence of the epidemic was very different depending on your ages, okay? Because all the cases of older people were more critical than the cases that we detected for the younger people. Then we decided to decompose or stratify these in different age groups. And moreover, now, 2021, if I have to do again my model, I will classify people not only by ages, but also by risk factors, okay? Like, for example, obesity that we showed in the previous seminar, okay? Well, and with all these elements, and taking into account that we were able to grasp what is the contact matrix between the individuals, and we have the mobility network that I asked to the Institute of National Statistics to start to play with the model. It allows us to describe the model and also to control what will happen with mobility and confinement. Okay, I mean, in our model, because remember that mobility is one of the parts of this big matrix M that control everything, you can confine part of the population. And we have some parameters like kappa 0, which is the population that is confined in these households. The confined population has a leak because you have contact with other households. Why? Because you have to buy groceries, then you have to go out of your place, or somebody come to your place to bring your groceries, okay? Then there is a small contact still between the different confined houses. It's not perfect. And the other thing is that those essential workers that are not confined will reduce their contacts by a social distancing, by a fraction delta, okay? And those are, these three parameters are key parameters to propose scenarios. What will happen if we do a certain lockdown, or if we open a certain essential service or non-essential service, okay? And well, you put all this together in the same way that I explained for the SIS, and you get up with this system of equations, which is complicated, but believe me that this can be solved, and it provides very accurate data. And we started to model COVID at the end of February 2020. The first results were pretty scary. And I tried to contact Instituto de Salud Carlos III. At this moment, Ministra Illa, it was the Minister of Health in Spain, no answer, okay? And the days went up and up and up, and then we did something. I say, okay, we have to come public because this information is important. And if these people don't take care of this, we will have a problem. We made a map about all the municipalities in Spain with all the data about the mobility between these municipalities, and we started to provide the forecast of the incidence of the epidemics in time, okay? We did this very, very soon at the end of February, and at this moment the contacts were already not fixed with the politicians or stakeholders that have to take actions. But after we published the web page, the people get interested, they showed it was something here, and then we started to receive calls from the Catalan government first and from the Spanish government second, sorry. And I have to say that in these interactions, the timing to answer to the crisis was very different from one and the other, okay? And this is the 2 weeks that we lose, and that created a major drawback in Spain. As I said before, this is what are the results of the incidents that we expect at each municipality in Spain. But remember that our model has also the clinical part. Then, according to the data that we got from the hospitals, that was public data, but nobody has compiled it before in a correct way in February 2020, we could predict what will be the occupation of the intensive care units, okay? And this is a snapshot of 18th of March 2020 that we predicted 1 week before it happens, with the occupation that we will have in the different intensive care units in Spain. And it was absolutely accurate of what happens in this day. Then we did a paper in Lancet in which, according to the limit of the intensive care units we have in Spain, we plot what will be the growing without restriction with the let's say mild lockdown that was proposed for the Spanish government, and what happens, and what happens if we restrict with a certain lockdown as we did at the end in March, in order not to collapse the health system, okay? Well, apart from this, remember that at the very beginning of my talk, we started with the reproduction number R. Okay, we can now compute the reproduction number in time for each age group, for each municipality. because we have this model that allows us to go through time and through geography. And essentially, we have this equation with this formula, which predicts pretty well what will be the basic reproduction number. Essentially, the first term is something like the time window multiplied by the infectivity, and the second part is the number of social contacts multiplied by the number of susceptibles. And with this, we predicted what will be the effect of the confinement for the different age groups in the values of RT, and we show how here we can reduce this below 1 and maintain the control of the epidemics on time. The mobility data that we used at the very beginning were imposed by the normal flow of people if no epidemic happens, which were the data from the INE. But then with Google mobility data and Facebook mobility data, we got better prescription, which is represented here, and that we use to predict what will be the effect of a certain mobility. But still, we didn't understood very well what was the role of mobility here and confinement. Then what we did is to grab some pieces, neglect the heterogeneities among the subpopulation, because there is people very, very different in different subpopulations, and assuming that the susceptible individuals remain constant in an intervention. Why this is important? Because we can simplify the equation and understand something what was very important, which is the dependence on the value of R on the confinement kappa sub 0 is quadratic, the same way it was for the mobility. Then this will force a phase transition in the incidence curve, and this allow us to understand something that was very important. Remember that people were telling you that we need to flatten the curve. Remember the flattening the curve? Okay, this is the diagram. We are flattening the curve when we are in values of social distance and confinement that are in this region. But for values on top of the region, what we will do is to bend the curve. And this was the goal. Why? Because essentially our social distancing in Spain is something very close to 0.4, computed with the data that we have and calibrating the model. And then it happens that flattening the curve for different values of confinement can do this so low. Remember that this is time, and the number is in log scale of new cases. We can arrive to millions, hundreds of thousands, or tens of thousands, or to bend the curve. Here we are bending the curve because we are already in this part of the transition. Then the total confinement one will be the one that reduced drastically the number of cases immediately and goes down. The other confinements that are not so strong were producing more and more cases where they become, at the end, deaths. Okay? Let's go to the particular predictions. Here we predict the daily new deaths and the daily new cases for Spain at different days. And here we implement the different log stages that we impose in our country. The results of the model and the data we have for the mortality for the different autonomous communities, as you see, is spread very well. And for the number of cases is also good, but not so good because some communities are out of the diagonal line that represents exact prediction. And it happens because the cases that were reported, they have a huge delay. And we have cases in Catalonia that were not reported to the Instituto Carlos III, who was the centralized unit to share this data up to a week or 10 days. And in other communities happen the same. Okay? Then to conclude, this highlights that the model is suitable for monitoring the evolution of an epidemic outbreak, especially in the acceleration part. It gives accurate information about the geographical spread, and it pinpoints the region at risk, and it's useful to project a scenario and evaluating the degree of lockdown that you need to bend this curve and stop the cases. The limitations of the work so far is that the mean field approach within the pages, in a patch, I cannot go finer I mean, if my municipality is Salou, inside Salou I don't have definition because I don't have data. Okay, the individuals are indistinguishable, and we know after a year of pandemics that they are distinguishable in terms of risk and in terms of activity. Okay, and the international mobility was not included so far, but this is very easy because it's simply when you open the border and you allow entering flights, etc. This mobility affects the epidemics in the same way we have seen before. I want to thank my main collaborators, that is Sergi, Jesus, Clara, David, Benja, and Joan. We did all this work. And here I put the reference that we have published with the model, and in particular, this first one is the particular model I have presented for the COVID, and that helps the government to implement the different lockdown measures and social measures. And that's it. Thank you very much.
Thank you, Alex, for this presentation. Maybe there are some questions in the floor. No? Well, I will start. So you say that this model especially works during the acceleration phase of the pandemic, and now hopefully we should be in the deacceleration processes, but there are new actors that appears in this big landscape. So one of the actors is of course mobility, not only international mobility, also national mobility, because the national borders were open again, and now we also have more, well, the rules and the conditions we had a month ago have been relaxed because the situation seems is getting better. But also there are other factors such as vaccination that should for sure works to deaccelerate this infection rate, this pandemia. But we saw yesterday in the session gave by Roger Paredes that there are some people who cannot get immunity, even if they are vaccinated, or even when they had COVID after they passed the COVID. And also there are new variants that can maybe modify this modeling. So my question, because I had other questions regarding clinical aspects that were not included in the model, but you were already answering this point, such as age, or as we saw in the previous with the previous speaker, obesity, for example, no? So, but now, despite of this condition, we have vaccination, we have mobility again. Seems that probably in summer, international mobility, at least if you get the COVID passport, no? And new variants that appears in the field. So, what do you plan to do with your model? Do you plan to include all these variables in order to have a prognosis of the future of this pandemic, or maybe further pandemics? I don't know. Or
we already did it. I mean, what I was presented is something we did in February 2020. During 2020 and 2021, we have been including all the factors that you commented. I mean, we have now the model that incorporates the emergence of variants, the vaccination process. We stratify by every single year of age. I mean, the model is simply easy to complete with the information that we have from outside. I mean, the main parameters that play the role that were mobility at the very beginning, as you say, and as far as the last months, because any restriction that we have about social activities like restaurants or discotheques or whatever, it's a part of this confinement that we are putting here. Okay, it's part of a partial lockdown, and we include everything. And then what we have been doing is to inform constantly the governments for them to take actions on the specific things. But many times, you know, politics is far from science and have other aspects. For example, we recommend the government of Spain not to open without test the tourists that comes from the UK, and it was not possible. And it doesn't make any sense when you have a new variant, which is the Indian variant, now called Delta, which is highly more contagious than the previous one, which is the UK variant that we have already in Catalonia. And then having cases of these, when we have the problem in the UK, they have seen people with one dose of the vaccine that got infected. We have only 30% of the population with this first shot. I mean, it's totally crazy from an epidemiological point of view. And then the model can be very, very accurate, but the information that is given, apart from the numbers, it's understanding, okay, what you can do and what you should not do, okay? And this is the most important part for me, because look, what happens is that in the world, there were only two strategies to control this pandemic. One is suppression, what the Asian countries, they have followed, that consists basically into go in this restriction up to a point with the number of cases is almost zero. And then you can apply strong control with testing, okay? And the second one is mitigation. That is the one that Occident has followed with awful results, which means that, okay, let the epidemics go, because your limit is the number of care units that you have into the system. Then you play with this like, okay, it go down, up, but still not crossing, we are okay. No, we are far from okay, because the number of cases in the population is so large that you cannot control with tests. Then you don't have any control of the epidemics. That was the main problem in Occident, okay? And the thing is that if, for example, in Spain, when I went to the facts the last time, I would say, okay, now that is the beginning of the summer, I'm saying summer of the last year, okay, where the number of cases were very, very decreasing and very low already. Then what we needed is to stay a little bit more on this confinement, okay? And people was like, come on, I mean, why? There are few cases, the hospitals are more or less okay, 50% of occupation, like now, okay? Now the thing is that we have the vaccines, and then it's correct, because we will speed the vaccination process, and we are in this competition with the virus, but we have a weapon, right? But in the last year, we didn't. And it was a total error to open and leave restrictions so early, because we have suffered the autumn, the fall, and the winter in a very, very bad situation, with 3 waves, with a lot of damage in the economical social subset because of the restrictions. And this was avoidable.
And have you considered in this new model whether or not all population will be vaccinated when the immunity starts to decrease again after the first vaccine? You know what I mean? So there is, of course, a delay. You get the immunity some days, or after the vaccination, and of course this immunity has also a window in which it's working and then decrease again. It means that we will need another vaccine, another vaccination processes. So, but of course, from the beginning to the end, there is a delay. So, if I'm not wrong, we start with the vaccination in Spain in December, I think it was, and we do not have the half of population already vaccinated with the double doses. And also, we do not have to consider only our country. Also, we have to consider other countries, because the ability, no? So my concern is about what will happen if the vaccination safety decrease before, starting the new vaccine round, let's say like this. So if you have to take this into consideration.
Okay, you put many elements on the table. There are several things, and the model can approach all of them. The thing is that we are still learning. Okay, we don't know anything about immunity, anything. I mean, we don't know if it will decay, if this immunity decay will be so important to make or to compromise the new infections. We don't know if the memory, well, we have some papers. There is a Nature of a couple of days where these lymphocytes B that will have this immune response for life for people that already had the COVID. Then the more I talk with immunologists, the more I realize that we still need time to make assertions and to say, okay, what will happen because this will happen like this? No, we don't know. The model can be complemented with the compartment of a new susceptibility. Yes, absolutely. This new susceptibility will come from the loss of immunity. We don't know. It can come probably more likely from the new variants, okay? But we are computing also what is the evolution of the virus itself, and the number of variants that it can generate is very slow for this particular virus, which is good news, but still not low enough for our vaccination program at the global level, because we need to vaccinate all Africa. And if we have this contact, the probability that this contest between the vaccine and the virus can unbalance in a moment. And then we will have a problem in which a new wave of SARS could happen. Then the situation is so uncertain now that the best thing that we can do is, okay, let's go for this massive vaccination as fast as we can. Let's try to compromise all the governments in this global strategy for the vaccination, and let's control as much as you could this new normality, which means essentially that in order to travel or in order to move from country to country, in this case, you have to have something. You have to verify your health status. Otherwise, we are risking all the previous process, everything. And well, let's see what happens.
So based on your experience, you think that it's still too early to open mobility as we have done?
Sorry?
Yeah, that I think. I mean, based on your data and your expertise on this, you probably think that it's still too early to open mobility as we did the last weeks.
Absolutely. See, it's a disaster. I mean, you have
holidays, a normal summer, let's say like this.
No. It cannot be. It cannot be. If we make this mistake, we'll pay it very, very high.
So we can expect a new wave after summer.
It's very likely.
Mm-hmm.
Very likely. It will depend. I mean, a new wave. Remember what I say. I mean, at the moment, the vaccination is covering the critical cases, and we don't have this limitation of the intensive care units. You will see a relaxation of the politicians, which is difficult to understand. Because if you have all these cases, you are protecting the system in the sense that you don't have critics or people that die. But what happens, for example, with the long COVID, we don't know much about this disease as to get rid of any restriction and say, okay, if you have COVID, it's fine. The medical studies on long COVID are worrying in the sense that we don't know much about people that pass the disease. It's really having no sequel at all, or the sequels can be something that we should worry about. And my point now is that it's a little bit crazy to think that a new wave in which there are no hospitalized or critical people, it's fine. I don't think it is fine, because a new wave, again, is an opportunity for the virus to mutate, and it's an opportunity for the human body to have sequels for life. Then we should avoid this very, very well. Otherwise, it will be a problem. And remember, we have vaccinated all the, let's say, more critical population, but we have a bunch of people unvaccinated that essentially are teenagers and kids. This is basic epidemiology. If you have a virus and you protect one of the sets of individuals that are susceptible, it will move to the other. And this is pure evolution, right? And that means that it will move to the young people and kids. And we don't know if this will provide the same kind of medical situations that we had with the previous variant, which was no harmless for them. But if we let the virus go to these ages with no vaccination, we will confront the problem in the fall, which is not clear at all. It will be very heavy. And that's a main concern for me right now. Yeah, understood. Yeah. So let's see if there is a last question. We still have time maybe for a last question from the room. Maybe there is no. Seems that there is no. So then, thank you, Alex. Thank you very much for this overview and also for this somehow prediction about the future. And then we will move to the next sessions. Thank you very much. Gracias, Mónica. Gracias a todos. Gracias a todos. So now it's time for junior and senior investigators at the IISPV. The first speaker is Christopher Papandreou. He's a Miquel Servet researcher. I'm just trying to share also my screen because he's in my computer. So he's a Miquel Servet researcher collaborating with me during the last 5 years in the field of nutrition, metabolomics, and chronic diseases, and more recently also in the study of gut microbiota in human health. Dr. Papandreou will present the results of an online survey that was already introduced by Dr. Jason Halford that we administered during the first wave of the COVID pandemic during the strict lockdown. So I'm going to share the screen, and then I will give the microphone now. Okay. I think, yes, I will move this there. I think you can see the screen in presentation. Yeah, so the floor is yours, Christopher.
Okay, thanks, Monica, for the kind introduction. So for the next few minutes, I'm going to present the results of a survey administered, as Monica mentioned before, the first wave of COVID-19. And also before Professor Jason Halford mentioned some results in brief. So now I'm going to talk in more detail. I declare that I have no conflicts of interest to disclose. And here in this slide, you can see on the left part a graph showing countries experiencing the lockdown measures. As expected, China was the first in which implemented these measures. In January 23 of 2020 started, and as you can see with the color that is red or more dark, the measures were very strict, and here you can see until June. We have also other countries. Spain is almost at the bottom. There was strict measures, especially during the 2 months, as you already know and experience. On the right part of this slide, you can see that the school closures and lockdown measures ordered most countries, starting with Italy and followed by other countries, including Spain. And the last, as you can see, was UK. Germany, especially lockdown, the middle of March to the end. Of course, there are consequences of these measures, and of course, the pandemic itself, because of infections and deaths. In this slide, you see the results of another study, cross-sectional study, including also longitudinal data, in which a representative sample of more than 27,000 UK adults analyzed and reported some mental health problems as well as health behaviors before and during the first wave of the COVID-19 lockdown. The proportion of population reported increase in psychological distress increase. However, loneliness didn't increase, as well as you can see, smoking decrease on the other hand. In addition, we can see increase in binge drinking, as well as frequency of alcohol consumption, at least 4 times per week. The measures adopted during this first wave and continue, as we know, second and third, such as lockdown, physical distancing, working from home, induce profound changes to normal routines, including unhealthy behaviors, such as inappropriate eating behaviors. This slide, you see what happened in the large sample in UK. The scope of this survey was to examine changes in people's eating behavior, including eating more, eating less, eating the same, during 8 weeks of lockdown. As we can see, a high percentage, a little more than 60%, reported no change in eating. A little percentage, 9%, was, as I remember, reporting no eating less, while, as we can see, there was increase in eating more in 16% of those subjects. Of course, it's not only the confinement that affects, as I said before, eating behaviors and probably mental health, but it's also the fear because of infection deaths. And here you can see that this is translated to stress, anxiety. So on the left part, you can see the results in which a third of population in the United States reported the stress, anxiety, and sadness. Canada, United Kingdom, and France, so almost a quarter of this, reported the same. In that time, was no previous study comparing different confinement, severities of confinement measures, so stricter or lighter. So take advantage of this gap in the literature. We aimed to evaluate eating behaviors and symptoms of depression, anxiety in a country like Spain that experienced greater severity of this COVID-19 pandemic and stricter lockdown measures compared to Greece. This was a cross-sectional online survey implemented in Spain during 23 of May till 18 of April, sorry, till 18 of May, while in Greece the period was a little shorter, was from 3 May till 20 May. Eligible participants were women and men at least 18 years old. So the survey included a brief paragraph explaining the objectives of this and took approximately 20 minutes to complete. It included questions like demographic, work status, anthropometric, before and during lockdown. Then we tried to see a little the changes with this approach. Data and habits as well. We use Mediterranean diet score, evaluate adherence to Mediterranean diet, for example, but also we assess changes in consumption of some unhealthy foods, as you can see. We also assess eating behaviors using the validated Dutch eating behavior questionnaire, which contain 3 domains: restrained eating, emotional eating, external eating. Smoking habits also were assessed, sleep duration, physical activity, and depression symptoms and anxiety symptoms using validated questionnaires. This survey was administered through different online platforms and mainstream social media, and to guarantee anonymity, questions about personal data were avoided. Statistically speaking, we use the classical approach, the student test, the chi-square, to assess difference between these characteristics between Spain and Greece. And then we perform a regression analysis in which the outcomes were the eating behavior domains, the 3 eating behavior domains I mentioned before, the depression score and anxiety score, and the exposures was all these variables derived from the questionnaire, and these were adjusted by age and sex. We use fast discovery rates approach to adjust for multi-testing. Then the next step was to take those variables that were consistently associated with the outcomes in both countries and treat living in Spain and Greece as a binary variable, with Greece as a reference. The outcomes were against continuous variables, the eating behavior domains, the scores derived by depression and anxiety questionnaires, and adjusted all this with all those variables that were consistently associated. And now you can see in this table that in Greece, the people reported more mean scores of restrained eating, emotional eating, external eating. Depression also was reported to be higher. No significant difference were found for anxiety. We also found that the age in Spain was higher. On the other hand, body mass index before lockdown was high in Greece. Smoking, carry smoking was high in Greece. Sleeping between 6 and 9 hours was higher in Spain, while more than 9 hours was high in Greece, and less than 6 hours high in Greece. Physical activity was high in Spain. The adherence to Mediterranean diet, based on Mediterranean score, was high in Spain. This is interesting because also in the literature has been reported in more representative samples. I mean the values, I mean scores. The change in weight was also reported to be high in Greece. The perception also for weight change, for weight increase high in Greece. The working status was that the current workers were more in Spain. Smoking also increased more in Greece, and unhealthy behaviors in terms of eating, like more pastries, they have changed the hours of meals, etc., was worse in Greece. And also the health status, however, the health status also was reported to be worse also in Greece. So here we can see the results from the associations taken between the exposures and the outcomes. So more or less we can see that out of 21 factors between the two countries, 12 and 11 in Spain, Greece respectively, were associated with cognitive restraint of eating. Similar observations were for associations of factors with emotional external eating, both countries, also with the depression and anxiety score. And when we adjusted for this, consistently associated with these outcomes in both countries, we found an inverse association between living in Spain and restraint as well as external eating. On the other hand, there was a positive association of living in Spain with anxiety symptoms. Data now from other similar surveys in other countries that experience strict confinement measures was like in China, for example, that depression, anxiety was high. In Italy, the same for anxiety, and in Spain, again, the symptoms of depression, anxiety were high too. Comparing now our results with studies that was before the COVID pandemic, was that the scores of restraint, emotional, and external eating was higher. And as we said before, interestingly, for the first time, we reported that a stricter lockdown was associated with lower restraint external eating behaviors. Regarding the frequency of moderate severe depression, when we compare now with, again, with studies, pre-COVID studies in more representative samples, we can see that in Spain and Greece was very low. The same was for anxiety symptoms. The data was only from Spain. Of course, our study has some limitations. All these surveys limit the sample representativeness. However, this is the only approach to be used during such occasions. The cross-sectional design also the studies limitation as well, because causation cannot be inferred. Another thing is that the high frequency of inappropriate eating behaviors, as well as you can see here, of mental health problems during the COVID, we don't know if because of the pandemic or the associated lockdown, because we don't have data pre-COVID for these variables. And the last limitation is that even we adjusted for several confounders, there is, of course, possibility for residual confounding. So in conclusion, high scores of inappropriate eating behaviors and high frequency of depression, anxiety symptoms in 2 Mediterranean countries with different confinement strict strategies and different degrees of pandemic. This is what we reported. And also living in Spain compared to Greece was associated with low restraint external eating behaviors and increased anxiety symptoms. Thank you very much for your attention. If there are any questions?
Yeah. Thank you, Christopher. I'm just gonna stop sharing the screen, and of course, if there is any question in the floor, now is time for ask. If not, just briefly, I would like to ask you if you plan to administrate another survey near future in order to evaluate differences between the survey you did 1 year ago, almost 1 year ago, and the new situation in Spain and in Greece.
Yes, thanks for this question. It's important. As we know now, as before also mentioned, was probably the expected fourth wave. However, there's something, it's not planned yet whether we administer. I think interesting will be to have this population that we ask in the first wave and follow during different periods. However, we didn't have, as I said, there was anonymity in the data. So it's not something planning now.
Mm-hmm. Okay. If there are no questions, let's move to the next speaker.
Yes, yes, of course. So the next speaker, it's Eva Satwe, who is a medical doctor and has a PhD in biomedicine. She works at the Catalonia Institute of Health and belongs to the support to the research unit. Eva is going to present results of her analysis on susceptibility and risk of COVID infection in patients living in the area of Tarragona.
Good morning. I will try to share my screen. I'm not shooting like. You can see my screen now.
No.
No, one moment, please. Now?
Perfecto. Sí.
I have my slides. See, I try to full screen.
Yes.
I have my slides in English, but if there is no problem for the audience, I will do my presentation in Spanish. Okay. Now, este trabajo forma parte de un proyecto más amplio, COVID-19 Tarraco Cohort Study. Ayer mi compañera, la doctora de Diego, ya presentó los resultados sobre mortalidad. Yo lo que voy a presentar son resultados sobre susceptibilidad o riesgo de infección, que son diferentes a los de factores de riesgo de gravedad o mortalidad. El objetivo pues, de este estudio fue analizar la susceptibilidad o riesgo de sufrir COVID-19 entre adultos en función de la presencia de diferentes condiciones médicas subyacentes. Repasaremos brevemente en esta diapositiva los métodos. Se trata de un estudio de cohortes de base poblacional que incluyó a más de 79.000 individuos de 50 o más años adscritos a 12 centros de atención primaria de la zona de Tarragona, 3 comarcas en concreto que tienen como referencia al Hospital Universitario Joan 23. Como variable independiente consideramos las diferentes características basales de la cohorte que incluían sociodemográficas, comorbilidades, medicación crónica e historia vacunal. Y como resultado principal, bueno, estos son muy parecidos a los que comentó ayer mi compañera. Lo que cambia es el resultado principal, que sería el diagnóstico de COVID-19 confirmado por laboratorio. La mayoría fueron confirmados mediante el test PCR, pero un pequeño porcentaje también con serología. El periodo de estudio fue entre el 1 de marzo y el 30 de junio de 2020, coincidiendo con la primera ola de la pandemia en nuestra zona. Como análisis estadístico utilizamos la regresión de Cox para estimar los hazard ratio ajustados de presentar la infección en función de la presencia de las características basales. Este es el flowchart del estudio. Aquí, aparte están también las fuentes de datos, que fueron básicamente los registros en la historia clínica informatizada del ICS, que el sistema que utilizamos es el ECAP, y también los resultados, por supuesto, de microbiología del laboratorio de Joan 23. Paso ya a los resultados e iré intercalando pequeños apuntes de discusión a medida que voy dando los resultados. Bueno, este será el orden en que los voy a presentar y paso a las tasas de incidencia. Hubo un total de 536 casos de COVID-19 positivo confirmado, lo que supone una tasa global de 39,5 por 100.000 personas semana. Como ven en la diapositiva, fue algo mayor en las mujeres que en los hombres, aunque esta diferencia en nuestro estudio no fue estadísticamente significativa. En cuanto a la edad, sí que vemos cómo la incidencia se dispara a partir de los 80 años. ¿Qué hay publicado respecto a esto en los estudios? Pues lo mismo más o menos que nos pasó a nosotros, ¿no? La COVID-19 ha sido asociada con el sexo, de modo que, aunque hay más casos en mujeres, parece ser que la infección es más grave en los hombres. Y en cuanto a la edad, sabemos que es el factor de riesgo más importante relacionado con mortalidad y también se asocia a susceptibilidad y gravedad de la infección. Pasamos a ver los factores que en nuestro estudio se asociaron a un riesgo aumentado de infección. El principal fue la institucionalización, es decir, estar en una residencia aumentó hasta 20 veces el riesgo de sufrir infección por SARS-CoV-2. Esto también es un hecho ampliamente descrito, incluso en UpToDate podemos encontrar cómo la COVID-19 afecta de manera desproporcionada a pacientes ingresados en residencia. Allí hay una alta prevalencia de individuos mayores, frágiles y con múltiples comorbilidades. Todos estos factores, además de aumentar la prevalencia y la severidad de la infección, pues tienen como resultado unas altas tasas de mortalidad. Entonces, en cuanto a comorbilidades, nos encontramos en nuestro estudio que en el global de la cohorte la enfermedad neurológica, que incluía enfermedad cerebrovascular y demencia, se asoció de manera independiente a un mayor riesgo. En la diapositiva pueden ver el hazard ratio. En el subgrupo de pacientes no institucionalizados, vimos cómo la enfermedad cardíaca, la enfermedad renal crónica y el cáncer también se asociaban a un mayor riesgo de infección. Respecto a esto, ¿qué encontramos en los estudios? Bueno, pues encontramos que la enfermedad neurológica es un factor de riesgo reconocido de gravedad y mortalidad por COVID-19. Por otra parte, también la enfermedad aguda cursa con manifestaciones neurológicas, no es infrecuente. Y lo que es ahora más el foco, ¿no?, de estudio serían las repercusiones neurológicas que podría tener la enfermedad. Respecto a susceptibilidad, hay menos estudios. Encontramos una cohorte de Los Ángeles en la que hallan que la enfermedad cardiovascular, la hipertensión, la enfermedad renal, la demencia y las condiciones de salud mental se asociaron también a una mayor susceptibilidad por COVID-19. Y un estudio que hay también del Oxford Royal College también encontró, bueno, como ha apuntado esta mañana el doctor Jay, que la positividad se asociaba pues la deprivación, la densidad de la población, la etnia, la obesidad y también la enfermedad renal crónica. En cuanto a las medicaciones que en nuestro estudio aparecieron asociadas a un mayor riesgo de infección, nos encontramos los diuréticos, los antiagregantes y las benzodiazepinas con los hazard ratio que pueden ver en la diapositiva. Respecto a los diuréticos, hay pocos estudios que los consideren de manera aislada, pero sí que hay algunos que los consideran dentro del grupo de los antihipertensivos. En general, las revisiones lo que encuentran es que no se asocian a un riesgo aumentado de infección. Si consideramos los antiagregantes, los resultados, que en general los estudios los presentan en asociación con los anticoagulantes, pues encontramos resultados opuestos. Y en cuanto a las benzodiazepinas, hay poca cosa en relación a COVID-19, pero sí que hay metaanálisis que las asocian a un mayor riesgo de neumonía. Respecto a los factores que en nuestro estudio se asociaron a un menor riesgo de infección, encontramos curiosamente el tabaquismo. Esto, bueno, nos sorprendió mucho, pero vimos que en el estudio que he comentado antes, el de la Royal College, también se vio lo mismo, ¿no? que el tabaquismo se asociaba a menor riesgo de infección, pero ellos analizaron también la gravedad y la mortalidad y los pacientes fumadores que enfermaban pues tenían una peor evolución. Esto es lo que luego también se ha visto en las revisiones y metaanálisis. Respecto a medicaciones que se asociaron con un menor riesgo de infección, nos encontramos los IECAS y los ARA2. Hay muchísimas publicaciones sobre estos medicamentos, ya que, bueno, pues cuando se descubrió, ¿no?, la puerta de entrada del virus al organismo, pero bueno, lo que los metaanálisis y revisiones concluyen es que no alteran ni la susceptibilidad, ni la gravedad, ni la mortalidad por COVID-19. Incluso hay algunos estudios que apuntan a que podían tener un posible efecto beneficioso, sobre todo en el subgrupo de pacientes con hipertensión. Las estatinas también en nuestro estudio se asociaron a un menor riesgo de infección y lo que encontramos publicado es que se descarta que se asocien a mayor riesgo, que incluso podrían tener también un papel beneficioso. Algunos autores han postulado también su posible papel adyuvante en el tratamiento de la enfermedad. Por último, la vacunación antigripal en el otoño anterior, pero solo en el subgrupo de pacientes no institucionalizados, se asoció a un menor riesgo de infección. Respecto a esto, acaba de salir un metaanálisis en mayo que también apuntan hacia esta asociación entre la vacunación antigripal y menor riesgo de infección. Fortalezas y limitaciones, destacar, bueno, que es una cohorte muy amplia, pero que tuvimos relativamente pocos eventos. Es muy representativa porque incluyó más o menos el 75% de la población del área, pero también está limitada a un área geográfica concreta. A pesar de tener un diseño retrospectivo y observacional, de modo que no podemos descartar factores residuales de confusión, el hecho de haber aplicado un análisis de supervivencia y de haber hecho múltiples ajustes multivariantes, creemos que confiere una alta fortaleza al estudio. También es un estudio que se enfocó desde atención primaria, pero al haber poca disponibilidad de test en aquel momento, muchos de los pacientes positivos acabaron ingresando. Conclusiones e implicaciones de este estudio: podríamos decir que las personas mayores, especialmente institucionalizadas, tienen una mayor susceptibilidad a la infección y la enfermedad en ellos es más grave y letal. Las personas con comorbilidades neurológicas, renales y otras también son especialmente vulnerables a la infección y tienen una peor evolución. Aunque las mujeres probablemente se infectan más, los hombres sufren las enfermedades más graves. El uso de antihipertensivos, tenemos que los pacientes que reciben IECAS o ARA2 no tienen un mayor riesgo ni de infección, ni de severidad, ni de mortalidad. Por lo tanto, se aconseja que continúen con su tratamiento, salvo que otras razones clínicas justifiquen su retirada. Lo mismo para otros antihipertensivos como diuréticos, betabloqueantes o calcioantagonistas. No hay evidencias sobre que se asocien a un mayor riesgo de infección o peores resultados, por lo tanto, no se recomienda retirarlos. En cuanto a los anticoagulantes y antiagregantes, también se recomienda que los pacientes continúen con este tratamiento, aunque sean diagnosticados de infección. Y las estatinas, lo mismo, especialmente deben ser continuadas en pacientes con alto riesgo cardiovascular, salvo que haya problemas hepáticos, renales o que no se pueda utilizar la vía oral. En caso de que interaccionen con los tratamientos propios de la enfermedad, lo que se recomienda es sustituirlas por otras. La vacunación antigripal debe ser también recomendada. Los resultados que acabo de presentar, más en profundidad, acaban de salir publicados en la versión online de Medicina Clínica y pronto estará también la versión en papel. Muchas gracias.
Thank you very much, Eva, for this
dejo de compartir.
Thank you very much for this nice presentation. I would like to ask if there are any questions. So I would like to ask about the potential mechanism linking comorbidities with COVID-19 outcomes. Because it was interesting that you have the smokers that are associated with the decrease. Because it's like one mechanism could be inflammation, for example. So it seems like smoking dampened inflammatory responses. And comorbidities could. How this is explained? Could you please tell us what mechanism behind it?
Realmente no tenemos una explicación muy clara. Pueden influir diferentes cosas. Una sería el registro, ¿no?, del tabaquismo. Nosotros cogimos los pacientes que tenían este registro, pero no sabemos hasta qué punto podía estar actualizado o era correcto. Por otra parte, puede haber también un cierto bias, un cierto sesgo, por el hecho de que los pacientes que fumen sean, por otro lado, más sanos, ¿no?, ya que las personas que han tenido alguna patología importante normalmente dejan de fumar. Esto podría también estar influyendo. De todos modos, no tenemos muy claro cuál es el mecanismo. Al principio se habló de la nicotina como un posible factor incluso protector, pero parece ser que no ha quedado tan claro. Lo que también es eso. Esto hablaba de susceptibilidad a la infección. La gravedad parece ser que en fumadores es mayor, con lo cual fumar no se aconseja de ninguna manera.
Okay, thank you very much. If there are no other questions, we can continue with the next speaker. Okay, there are no other questions. So the next speaker is Mr. Manuel Ruiz, who is a biotechnologist, engineer in informatics. He's working in the Sepsis Inflammation Safety Research Group at the hospital in Tarragona. Manuel will present a clustering analysis to identify risk factors for mortality in critically ill patients with COVID-19.
Hi. Can you hear me?
Yes.
Okay, yeah. And you can see my screen?
Yes.
Okay, thank you. So as you said, I'm going to present you our study deploying unsupervised clustering analysis to derive clinical phenotypes and risk factors associated with mortality risk in 2022 critically ill patients with COVID-19 in Spain and the impact of corticosteroid treatment in the whole population and each phenotype derived. First of all, I want to say that I have Dr. Alejandro Rodriguez here by my side. So if at the end of the presentation there's any clinical question, he will be able to answer them. Okay, well, I'm going to talk to you about the background, the objectives, and then I will explain the methodology used, and finally the results and the conclusions. For the background, we have that for some recent epidemics related to coronavirus infection, we have obtained, well, not we, it has been discovered that the use of corticosteroids was associated with delayed virus clearance. And also the use of corticosteroids is associated with higher mortality and more complications. But for COVID-19, some randomized control trials, like this one, dexamethasone in hospital-aged patients with COVID-19 from the recovery collaborative group, and some clinical guidelines have recommended use of corticosteroids to all patients with severe COVID-19 during the second wave and after the second wave. However, there is limited data in relation to the ICU admission beyond 28 days that assesses the side effects of medium and long-term glucocorticoid treatment, and consequently, the findings from these studies are limited. There's already some papers that criticize and state the limitation of this recovery paper. And this paper in concrete have concluded that the absence of stratification and incomplete information about some factors associated with the outcome may have resulted in an imbalance between the treated and the control groups, and also that the beneficial effects at the relatively short 28-day mortality endpoint may not translate into long-term benefits. So the objective of our study is, first of all, to determine if there is a presence of clinical phenotype, distinct clinical phenotypes, using unsupervised clustering matching instead of studying the whole cohort of COVID-19 patients together. We want also to assess which factors are independently associated with the ICU mortality in the whole cohort of patients and also inside each phenotype. And finally, we want to determine if the use of corticosteroids is associated with the ICU mortality in the whole population and inside and in the pre-specified clinical phenotypes. So the methodology of our study is a prospective observational cohort study with 2017 critically ill patients older than 16 years old from 97 ICUs of Spain. We have used demographic, comorbidities, clinical and laboratory findings at the ICU admission since the start of the pandemics until August. And obviously, we have informed consent from all of the patients, and the study has been approved from the ethical part of the hospital. The methodology is divided into two parts. The first part is for the derivation of the phenotypes and also in order to understand the risk factors of these phenotypes. And the second part will be where we study the corticosteroid use in all of these clusters. For this first part of the methodology, we have done first a classical model of logistic regression, where we selected the variables by the mortality table, and then we did a logistic regression model in order to understand the risk factors. But secondly, we did a variable selection by the information value and selected the 25 more important variables. First, we did a logistic regression model and understood the risk factors of the whole population. And secondly, we did an unsupervised clustering analysis. For each cluster, we did a variable selection according again to information value. And finally, we did a logistic regression for each of the clusters, and we obtained the risk factors for each of the phenotypes. We have to mention that the corticosteroid treatment was defined as the administration of these two drugs within the first 24 to 48 hours prior or in the first 24 hours of the ICU admission. Therefore, we obtained that the corticosteroid wasn't associated with the outcome. Therefore, the corticosteroid wasn't used for cluster derivation. And this means that any further impact can be seen as unbiased and independent from the second analysis. In this second analysis, first of all, we did a propensity score full matching with the whole cohort of patients. And once we had a weight associated with each patient, we did a logistic regression model in order to understand the risk factors associated with the ICU mortality and check if the corticosteroids were associated with the ICU mortality. And then for each phenotype, we did a Cox proportional hazards regression and checked if there was a violation of the proportional hazard. For those phenotypes that there was this violation, we did a time-dependent Cox regression and a weight Cox regression. So now I'm going to talk to you about the results of these studies. For the first part, we already have a paper published in the Critical Care Journal, which covers the derivation of these clinical phenotypes and also understanding the risk factors of these phenotypes. We obtained these three phenotypes. The first one is the mild phenotype, or the A phenotype, where the patients are less severely critically ill and don't show a lot of complications. a lot of medical complications. In the second phenotype, in the moderate phenotype, we can see that the patients are the same critically ill than the A phenotype, but they tend to present septic shock. And finally, the C phenotype, the severe phenotype, we can see that the patients at order are more severely critically ill, and also they present a lot of more complications like hypertension, shock, or myocardial dysfunction. Here we can see the percentage of mortality for each one of the phenotypes, and also the risk factors for all of the phenotypes. We can see that there's a difference in the proportion of mortality, but also that some risk factors like gap antiviral only appear in some phenotypes. In this case, gap antiviral is only a risk factor in the A phenotype. Once we understood the phenotypes, we studied the corticosteroid treatment in the phenotypes. For the A phenotypes, we can see that there is no relation in the hazard ratio between the use of corticosteroids and the ICU mortality. But we can also see it in the graphic, because both lines, the one that represents the use of corticosteroids in patients and no use of corticosteroids in patients, have the same survival probability a long time. For the B phenotype, we can see that the hazard ratio states that there is a relationship between the ICU mortality and the use of corticosteroids, but this hazard ratio cannot be accepted because in the graphic, we can see that before the 20 or 25 days, there is a separation between the use of corticosteroids, the survival probability of the use of corticosteroids, or the survival probability without using corticosteroids. But after these 20 to 25 days, we can see that both lines start to merge and start to cross. So the survival probability of those patients that have received corticosteroids is the same at the end that the patients that didn't receive corticosteroids. Therefore, we had to do the time-dependent cost regression, and we obtained that for the first 16 to 20 days, the hazard ratio is protector. So the use of corticosteroids in these first days, in this B phenotype, is protector. But after these days, we obtain a hazard ratio of higher than 1, which translates that the use of corticosteroids indicates that there's a higher probability of dying in these patients after these days. Finally, we did the weight cost regression, and we found that the corticosteroid treatment wasn't associated with the ICU mortality. In the C phenotype, we obtain the same that in the B phenotype. There's a hazard ratio that is protector, but this hazard ratio cannot be accepted because of the cross of the lines of the survival probability in the Cox regression graphic. Then we did, again, a time-dependent cost regression and a weight cost regression. For the time-dependent, we obtained more or less the same. Before the 16 to 20 days, we found that the corticosteroid treatment was protector for mortality, but after this time, we found that there was a relationship that stated that the use of corticosteroids make a higher probability of dying. But when we studied the weight cost regression, we found that the treatment of corticosteroids was associated with less ICU mortality. So, as the conclusions of our study, we found that the heterogeneity of COVID-19 patients requires machine learning approaches in order to define phenotypes and not study the whole cohort of patients together. Also, we found that phenotypes are correlated with host response patterns and the ICU mortality, and also that there are different risk factors across the whole population and the clinical phenotypes. Third, that our findings were against the widespread use of corticosteroids in all critically ill patients with COVID-19 at moderate high dose. Also, that only the patients with higher severity could benefit from the steroids treatment, although the effect was lost during the ICU stay. Thank you very much. That was everything.
Thank you very much.
Okay.
Thank you, Manuel, for the presentation, the nice presentation, the interesting results. I have one question. When you got these clusters and the scores derived by this, did you check for any interaction? So you have a treatment and to test the interaction with the scores. Did you test this for the outcome?
If we check, sorry.
Sorry, the regression model to test the interaction with the scores. So you have the treatment and to test the interaction with the scores you mentioned before as a categorical variable. So you create the different the scores derived by the different clusters.
Okay, yes, you mean when we created the clusters?
Yes, you have make the clusters.
Yes.
So these phenotypes and create this categorical variable and to test interaction with this, whether there is interaction with this or the treatment. Have you tested this?
If there's an interaction between the treatment, the use of corticosteroids and each cluster.
Yes.
No, there's no relationship between the derivation or the creation of clusters and the corticosteroid treatment, because I mean we had a lot of, well, not a lot, but we had all of the treatments that were used as variables, but these variables weren't important enough by the information value. Then we only use these 25 discretized variables for the unsupervised clustering analysis. So there's no relationship between, or at least there is no impact of the corticosteroid treatment in the creation of the clusters. I don't know if that's what you asked.
It's okay. No, thank you very much. Because we have now limited time, we need to proceed now with the disclosure, closing remarks. So Dr. Elizabeth Villella, we can continue.
But before the closing remarks, I would like to ask a question to Manuel. So Manuel, please keep here.
Okay.
My question is, well, to know how these results changed the way patients were treated with corticosteroids.
I mean, are you asking if clinical should change what they are doing nowadays?
Yes.
Okay. I mean, first, I think we should validate the results, obviously, and we intend to do it in the next months. And if we obtain obviously the same results, probably I think the clinicals here would be able to introduce the data in a web, and with this data that they introduce, we will tell to the doctors if the patient belongs to the A phenotype, the B phenotype, or the C phenotype, and the doctor should decide if they use corticosteroids or not at the end. I mean, the decision is not made by the clustering or by anything. The decision at the end has to be made by the doctor, but we support the decision of the doctor, telling him how critically ill and the complication of the patient, how contribute.
Okay, thanks. So now I'll go to the closing remarks, but because the number of participants connected is dropping down quickly, just to thank to the speakers, especially the researchers at the IISPV, and see you in the next seminar. Bye-bye.
Bye.
Thank you. Bye.
Thank you.